at the Innovation Agency, we classify innovations and solutions into categories and themes which reflect the transformation and redesign challenges that we're all facing as our health and care systems become more integrated. We do this to support a culture of innovation that helps systems with transformation and also with improving care and safety through the adoption of those innovations. So one of our main areas of focus currently relates to how NHS hospital trusts can manage the complexity of dealing with COVID patients whilst maintaining the restoration and normal delivery of elective and outpatient services that were scaled down during the first COVID wave, unfortunately. And today's conversation is therefore going to focus on how we can achieve this. So to our speakers, first we're going to hear from Andrew Michelson, Head of European Operations at SERENUS.AI Limited. Andrew's a recognised expert in healthcare informatics with more than 30 years experience working for NHS and independent organisations in the UK and USA. Andrew will be co-presenting with Prof. Hemant Pandit. Prof. Pandit is an NIHR Senior Investigator, so National Institute of Health Research Senior Investigator, a Professor of Orthopaedics and an Honorary Consultant at Leeds Teaching Hospital NHS Trust, a Director of Research and Innovation at Leeds Institute of Rheumatic and Musculoskeletal Medicine. We're also going to hear from Steve McKenney and Sanjay Kanwar. Steve, before co-founding C2AI, was actually a barrister with a special interest in medical law, and he's former head of quality, safety and clinical governance in the Department of Health. Steve's going to be co-presenting with Sanjay, who's a senior consultant general surgeon at St Helens and Knowsley NHS Trust. And they're going to be discussing using AI systems to prioritise patients effectively, to track, reduce and prevent complications and harm. And Steve's going to give an overview of the company as well. So those are our speakers for today, and we're going to go to the first session just shortly. Before we start, you'll notice that the chat has been disabled, but we are interested in hearing any questions and comments you've got, and you can do those through the Q&A function that you should be able to see at the bottom of your screen when you hover over the bottom of the screen. So do feel free to put your questions in chat. We'll keep our eye on that in the Q&A, and we'll respond to those questions between speakers and at the end of the event as well. So hopefully that's clear and you can all access that. Also, just for housekeeping, you will know that we're recording this event, so I'm just hoping that you're comfortable with that. And also, just so you know, everyone on the call is muted today, just to make sure that we obviously don't disturb the presenters when they're in full flow. So thanks very much indeed for everybody, panelists and delegates, for taking time out of your busy schedules to join today's discussion. I'm now going to hand over to our first speaker, who is, I can't remember, who's going first? Sorry.
I believe it's
Andrew. Yeah, I thought it was you. Yeah.
Okay.
Thanks,
so
Andrew.
Hopefully you can see our presentation and hear me. So I will. So first of all, hello everybody. As Mike very graciously introduced me, I'm Andrew Michelson, Head of European Operations for SERENUS.AI. SERENUS.AI is a company that is devoted to providing a innovative solution to the problems of how to make accurate, dependable decisions post-diagnostically for the best treatment and care for patients. And I'm going to talk a little bit about how we do this and what we do, and then I'm going to hand over to my colleague Hemant Pandit, who's a strong champion of ours and who we're working with closely at Leeds Teaching Hospitals. So first of all, our leadership team, just a quick introduction. Hillary, who's actually in the audience listening today, is our co-founder of the company. She is an attorney at law and a very successful serial entrepreneur in Israel. Prof. Elidan, who's one of the senior ENT specialists in Israel, in fact in the Middle East, and also has got a strong record of working at governmental level within Israel as well as being our Chief Medical Officer. Dan has a strong background successfully starting up and running technology for internet startups. Prof. Galaladan, who is a professor at Hebrew University and also a visiting lecturer at Stanford, is our expert in artificial intelligence and machine learning. And then our co-chairs, Ethan Efrati is also an expert in computer science and a visiting fellow at Carnegie Mellon University. Mike Netz, our other co-chairs, a former CEO of Teva Israel, and was their VP of Global Innovative Products. Of our general team, Dr. Shannon, you see here, is our main algorithm researcher. As well as being, a recognized expert in his field, he's also got direct experience of successfully starting a medtech startup in Israel as well. And then lastly, our medical experts, and the key is, as I'll discuss as we go through the presentation, that the key to our system is having the input of medical experts in all the fields that we cover. And you can see here that all of our medical expert team are either professors or are heads of department at prestigious medical centers across Israel. And of course, we are rapidly moving to expand our medical expert team, starting in the UK with our fabulous partner, Hemant Pandit, who you'll hear from shortly. So what is it we're trying to resolve? The issues that confront the accurate and cost-effective and clinically appropriate treatment of patients post-diagnostically are well known and well understood by most NHS stakeholders. You can see that in 2015, Bruce Keogh at that time had highlighted clearly the extent of the problem at a national level. 1 in 7 procedures being unjustified, 1 in 20 hospital stays he characterized as a waste of money. Much more recently, we've seen similar issues on national news footing around tonsillectomy. We know that there's a large proportion of particularly knee arthroscopies and total knee replacements that are deemed unnecessary or could be deemed unnecessary as well. So how do you address this? We believe that the solution is our AI-based platform, SERENUS.AI, and let me just tell you a little bit about what it is and why we're so confident about it. So the keys to success, we believe, are a combination of power, breadth, depth, but also simplicity. So in its simplest form, SERENUS.AI ingests information either from medical records, particularly where patients have already been referred and accepted for surgical intervention, but are now sitting on backlogs. Those indicators can be ingested into the system directly from a medical record, or in the case where a patient is presenting in person or more typically by virtual consultation these days, there's a very simple chatbot interface that allows a clinician to rapidly move through the consultation with the patient. That information is fed into our machine learning engine that combines our algorithms with the scoring and input from our top medical expert panel, the latest guidance and research on an international, national, and local level. And all that churn looks at the entire set of factors holistically for that individual patient and produces a detailed report, go, no go, prioritization, and suggestion of alternative measures that might be appropriate in some cases. The way this is presented on screen in report form to the clinician or whoever is in this case triaging is in terms of a recommendation of whether there is or isn't an indication for the referred procedure. If not, what the alternative measures should most appropriately be. And then also, most importantly, provides a detailed rundown of the factors showing the metrics by which that decision was reached at. So green for in favor, red against. And you can see there are a lot of different factors that are taken into consideration. We believe conservatively that a decision tree system like NHS Pathways would have to span around 9,000 branches in order to arrive at the same depth of decision making and recommendation that SERENUS.AI does in the space of about 2 minutes. Lastly, the back end of the system is a very advanced analytics platform. What's particularly tuned for as the system is used, the system learns, through machine learning, and that learning is used to look for and flag up new insights in clinical practice. So our goal is always not merely to replicate the decision making of top independent consultants like Hemant, but actually to find, look for potentially new, improved insights into practice as well. Our overall proposition then is that we feel that our system, and we can demonstrate that our system is a great solution for prioritizing the burgeoning waiting lists that I know Hemant's going to talk about in some more detail, improving patient outcomes at the same time as reducing cost and resource burden upon the NHS, reducing risks from inappropriate surgical interventions, and of course significantly enhancing data quality and data flow, particularly since the system is capable of putting very enriched data back into electronic patient records on the back end of its use, and significantly uplifting the quality of record keeping in electronic patient record systems. You can see that from previous from evaluation of the system from trials that we found that in snapshots taken that 40% of results the system was able to identify where there was no indication for a procedure, and that 12% of cases the system accurately determined that the important criteria necessary to make a sound decision were missing and flagging up what needed to be captured. The company itself has been awarded a number of grants and awards in the 3 years that we've been operating, both from governmental agencies and from prestigious private sector organizations like Ernst & Young, and most recently AstraZeneca. Also this year, our CEO, Hilary Harrell, was awarded the Department of International Trade's European Women in Tech Award for 2020, which we're very proud of. And the company continues to go from strength to strength. In terms of our competitive advantage, I mentioned before about comparison with simple existing decision tree type systems. There are key, as you can see, clear areas where SERENUS has a huge competitive advantage in terms of the benefits and value that it delivers compared to sort of more conventional methods as used in healthcare systems today. Lastly, what do our partners say about us? Well, Hemant you're going to hear from in person momentarily. We also had very strong endorsement from a number of people like Professor Braverman at Hillel Yaffe Medical Center, who feels strongly that the system can and should be used across all of the range of procedures that it supports. It's worth noting that we do currently support 40 procedures within the system, covering 10 different areas of medical and surgical practice. A very strong one for us, of course, is orthopedics, which Hemant himself is going to address directly himself. So without further ado, I will introduce you to my colleague, Professor Pandit, who's going to talk about COVID-19 clinical prioritization of patients.
Thank you, Andrew. Could you go to please next slide? Thank you. I hope all of you can hear me. If you can't, Andrew, just give me a shot. As we all know, we are currently just about in the middle of second surge of COVID, especially here in the Northeast and Northwest. I'm sure Sanjay is going through the same problems, and so is rest of the country. Currently in our region, we have more than 10,000 patients waiting for surgery and 250,000 patients waiting for an outpatient appointment. There are huge issues with capacity, with workforce, as well as the supply chain able to deliver the bits that we need when we open our doors, because we cannot just work at 100%, but we have to work at 150% to clear our backlog. Last but not the least, the COVID scenarios are changing almost on a day-to-day basis. The way we are told by PMO's office what needs to be done changes, and sometimes it is evidence-based, sometimes it may not be very obvious why we are doing what we are doing, but the bottom line still remains that the goalposts change quite quickly. Next slide, please. And some of you, if not all of you, will be aware that the way the NHS is going to function in the coming years is by 2021, everybody will be part of an integrated care system. We were one of the 18 who are already ICS. Ours is the West Yorkshire and uh, acute trusts, and there are 6 trusts, 15 hospitals in our region. We look after a population of 2.2 million. And the primary push in all this is to break down barriers, make sure that patients who live in a region do not suffer from postcode lottery. There is a talk about single waiting list with all patients prioritized as per what is needed from their clinical perspective in terms of prioritization, rather than a patient living in, say, Huddersfield will get an operation quicker as compared to Leeds because their waiting list is smaller. We also know that more people now live with at least 2 long-term conditions, and currently the number in UK is about 15 million, which will increase by another 20% by 2025. It has been shown in various NHS documents that obesity, poor diet, and lack of exercise are 3 of the biggest risk factors that do contribute to early deaths. Next slide, please. Therefore, with all this background, it is really important that the patient flow is optimal. It's a shared responsibility between the patient, the primary care, and the secondary or tertiary care. We do not want the patients to travel distances to attend outpatient services, to offer perioperative care, and also to conduct various diagnostic tests or follow-ups. If we also need to discuss with the patient alternative therapies, and these therapies need to be evidence-based. Therefore, it is important that there is active patient involvement and patient understands with the current scenario, if the patient undergoes an intervention, typically we are talking about surgical intervention, what is the likely outcome going to be? And if the patient and the surgeon can change certain modifiable factors, and this of course is not only the surgeon, but of course more importantly the patient. So if the patient loses weight, patient gets his blood pressure under control, the arthritis gets worse, whatever it is, then that will help us optimize the patient flow, optimize the treatment, and therefore able to provide the right treatment to the right patient at the right time, and I may wish to add at the right place. This will of course reduce the variation in clinical practice, and NHS will be able to do better than what it is currently doing. Next slide, please. With all these, there are clearly benefits to the system. It is cost effective, it will be clinically driven, and of course you need a bespoke model, because what will apply, say, in orthopedics is not going to apply in general surgery. The patient questionnaires are different, the risk factors are different, as well as the outcome measures are different. Clearly, we need to have access to data which is paperless, which could be easily transferred both ways. So it's a two-way communication, and one should be able to access it at touch of a button, not going through multiple notes. And therefore, the follow-ups has to be patient-centered and patient-initiated. Nowadays, there is a huge push from CCGs, and this is coming because of the aligned incentive contract rather than the PBRs, that income that a trust will generate is dependent upon the outcome and the patient satisfaction, and not necessarily the number of patients or the number of visits that a patient does. Next slide, please.
That was actually your last slide, Hemant.
Okay, I'm sorry, I apologize. So the gist of it is that this is where the problem is. And I think a AI-based technology which will help us deliver all these elements in a reasonably painless manner is what currently and in future the NHS is going to need. I look forward to hearing the other presentations, and also very happy to take any Q&As. Thank you.
Thank you very much. Thank you, Hemant. Thank you, everybody, for your kind attendance.
And thank you very much indeed, Hemant and Andrew, for that really insightful presentation. I think it's great to hear about how an approach, such as the one you've described with SERENUS.AI, can really help trusts manage their patient flow at an absolutely crucial time. And I think the numbers are stark, aren't they? Prof. Pandit, you described 10,000 patients waiting for elective surgery and 250,000 waiting for an outpatient appointment. And just to stand still, clinical teams have to run, in trusts, they have to run at 150% of capacity, which is not possible, just to keep up. So the way in which you've described, an approach to finding a way of ensuring that the right patients are brought in for hospital care is absolutely essential. So I'm just checking the chat box or the Q&A box. I don't see any questions just yet, but we have got time. And just in hearing that, I've got one or two questions that I might just ask as well, because we have got time. So I guess this is to perhaps yourself, Andrew, and Professor. It's a question about the difference between your system and alternatives, such as the existing decision trees. Do you want to just expand on that? You touched on it in your presentation.
So I think that, as I said before, I think the key is, and it was Galaledvan who first pointed this out to me, that the way that our system works, combining artificial intelligence algorithms in order to train the system and to identify the factors that are key to determine how that information that is provided through our medical experts should be combined most effectively with with guidance and best practice. Combining that then with the deep machine learning that actually rapidly cuts through that data, and you can actually see on screen, because the system feeds back to you, from in some cases, trillions of different permutations across all the factors to rapidly, within about a 2-minute interview, get down to the where you're dealing with a patient face-to-face, that is, get down to the point where it can make a strong and reliable recommendation. The system is designed from the get-go, and one of the key inputs and quality assurance measures that our medical expert team use is that the system is designed to replicate on a reliable every case basis the decision making of a top objective medical expert, of a senior consultant. If the system, when we show this to people like Helens and other consultants that we've run through demonstrations with, the most typical response from them is, "Oh, well, I would have come to that conclusion," and that's exactly what we're looking for. We're not trying to replace the consultant, quite the opposite. What we're trying to do is to bring that level of knowledge and experience that they have into a broader base of clinical practice.
Mike, I may wish to add something, and probably I didn't make it clear in my presentation.
Go ahead.
One of the problems that we have in NHS is that when a patient comes to see us, not only the referral is not structured, it is quite vague at times. And to tell you the truth, the referral system is quite clunky. And I have to go through 20 pages, which somebody has already triaged the patient, to get to a meaningful point, which could be just one line. Then, when I see the patient, the clinic is shared with me and my fellows or my registrars, who keep changing every 6 months to 12 months. And therefore, there is a huge personal, what should I say, not necessarily evidence-based methodology, which takes into consideration one's own experience to a certain extent, and it's more of a gut feeling. So you are very subjective in deciding what you want to do. And it happened 2 days ago. I saw on someone's list, a patient got cancelled after he has waited for more than a year, 60 to 64 weeks to be precise, when he came for surgery, because the surgery was listed by a colleague of my colleague, and then he is now transferred to someone else whose decision is, well, I don't think he needs surgery. So not only this patient has waited for 64 weeks, but also we have wasted that slot in today's world, which is like gold dust. And if we can get to a objective manner in which we can engage with the patient, and this process then will be iterative. And that's what I hope AI will be able to deliver. Thank you. SERENUS.AI. Yeah, thank you.
Thank you, Haman. And I think, you know, a great additional response there. And I think, you know, importantly, crucially, you know, we talked about a patient experience here, and I think that's absolutely core to you know, the centre of what we're trying to describe here today. It's about, you know, providing the best options and outcomes for the patient, and nothing unnecessarily so. And certainly, you know, for somebody to wait for 64 weeks, then not to have a procedure because it's decided that it's not needed. You know, that you know, if I was that patient, you know, I'd be feeling all kinds of things right now. I think we've got time just for one more question, and it's the inevitable question. I'm going to ask you, Andrew. We've talked about, you've described, both Hemant and yourself have described, you know, there are efficiencies, there are, you know, transactional efficiencies that no longer need to take place through the refinement of the operating list and so on. I've got to ask about, you know, what can this produce in terms of cost savings for anybody that's, you know, a potential purchaser on the call today, on the Zoom today. You know, what would be, you know, what's possible for taking this approach to managing your waiting lists?
So I think the headline number, I guess, which is an easy one for anybody working within the NHS to calculate, is based upon, you know, our expectation that the system can identify between 20 to 40% of surgical referrals that are unnecessary. And you know, it's well published what on a national and regional level what the cost of particular surgery types are. So I'm not going to sort of bore people with numbers here. I'm happy to always discuss details offline or in one-to-one conversations. But the obvious headline there is it's relatively easy to calculate that there's a significant and very significant return on investment simply based upon avoiding the costs of unnecessary surgeries. But then you've also got to look at all the other on costs as well. You know, where you have unnecessary surgeries, how many of those are going to result in complications that are going to lead to unplanned emergency readmission for patients? How many, and what cost does that come with? What cost to the broader economy, to the patient themselves and the patient's family of lost work time and both during waiting for treatment and then recovering post-operatively. So the overall the fuzzier costs are potentially significantly higher even than the direct cost savings to the NHS, which themselves are significant.
Yeah, it's a difficult question to answer, and the common sense says that if you do less procedures, you won't be spending as much money to do them. So there is obviously a saving there, but you're right that it's the collateral impact as well that would have a significant impact.
Mike, sorry, just one other thing as well to keep in mind is at the moment, you know, there are only so many consultants in the NHS. You know, you can't, until somebody comes up with a consultant cloning machine, you know, there is a general need to improve the quality of decision making right back upstream into primary care and onto the GP desktop. And the reality is that a system like SERENUS.AI is critical and can deliver real savings as well as improvements in efficiency by making it clinically safe for clinicians of an SPR grade, potentially even you know, experienced practitioners in nursing, but certainly general practitioners and clinicians in the community to be able to step in further up the pathway before the patient even gets to a consultant.
Okay, that's great, Andrew. Thank you. Now, I have got a question actually in the Q&A, and I think I'm going to ask you actually, and it'd be good to hear from Hemant on this, and possibly Sanjay as well. So, in the panel's view, to what extent is the resistance to technology change, and indeed science, from patients, and to what extent is it from clinicians? So I guess that's the question around the AI approach. You know, is there resistance from clinicians, and is there resistance from patients to the notion of, you know, an algorithm making a decision?
Sanjay, do you want to take it or you want me to take it? I don't mind. I mean, of course, who wants to go first? Whichever way.
I don't mind, I'll start. I don't think there is much resistance. I think it's more so there's less experience really. In general surgery, there are 1 or 2 decision trees systems out there, but I don't know of any facility in the Northwest that actually uses that. The biggest problem that we have in hospitals is having a system that is not funky. You know, most of our hospital systems do not talk to each other. So it makes the life of the clinician really quite difficult to go through either paper notes, electronic notes. For example, I'm just finishing a clinic this morning, and I will spend 15 minutes going through the hospital systems, only spend 5 minutes with the patient trying to explain things as to what we're doing. And so the systems are not very user-friendly. So if they were a little bit easier to use, and some systems are, then yes, I think clinicians would actually embrace that. And I think on the whole, patients would trust that decision. Hemant?
Yeah, no, Sanjay, I think you're absolutely right. If we have a IT system which spreads across the primary care, secondary care, with access for the data, that the patient's own data to the patient and to the person who is seeing the patient at that time, then everything becomes far easier. And the reservations people have is because that access is not as easy as it should be. Now here in Leeds, we are hoping to be a digital city. We have access to primary data. There is a single platform through which everybody can access the information. So my GP can, not my GP, let's say if I was a patient, my GP, he can see what all medications I have been offered, as well as what interventions I am undergoing throughout the entire pathway of my journey for a particular intervention. And it really works well in those cases, but we still find at times it is clunky. And patients, to be fair, are very open to this type of embracing these things. What the patients find really difficult is they go, let's say they go to a GP with knee pain. The GP refers them to a MSK triage. It takes MSK triage probably 2 months to see the patient. Then the MSK triage offers them treatments which are not necessarily at times evidence-based, where you need to tell them, this is what you need, because we have put in your information with, if you had an intervention or you did this, this is likely to be the outcome. They don't do that. And invariably, the patient will be told, you have severe arthritis, in inverted commas, where that severe is not at all severe when it comes to when I see the bits that matter to me. After waiting for a year, the patient comes to me with the understanding that he or she is going to do very well if he undergoes this particular intervention. And then I only turn around to tell the patient, and remember, he has now waited for 12 months, that you know what, you're not going to do well. And it really becomes a huge problem for me at that time to turn the patient back. And in a small number of patients, you end up getting patient complaints. And I really feel bad about it. If I was the patient, I will feel let down. Okay. So if that's what the problem is. Thank you.
Thank you, Hemant. Thank you, Sanjay, for that really passionate response from both of you. And I think from a technology perspective, we're pushing against an open door. It's the technology that we need, not to win the battle of hearts and minds with patients and clinicians. Fascinating insight, and thank you. So we're now going to move on, and we're going to hear from Steve McKenney and Sanjay again from C2AI. So over to you, Steve and Sanjay.
Thanks very much, Mike. Can everyone see my screen? I'm not going to do death by PowerPoint. I'm just going to do minor injury by PowerPoint, hopefully. And I appreciate you putting us together on the same platform, Mike, because I think there's a real complementarity there, that SERENUS appears to be the ones who can help you make the most appropriate decisions. And we sort of kick in with what happens after that. How do you minimize the risks, stop problems happening from the treatments that you've proposed, and improve the quality of your outcomes? And that's where I'm going to spend a little bit of time just painting a picture of what we do and our ethical background, because it's quite important context that this was built also by, with, and for doctors. And here's another one coming into Sanjay's room, who's my good friend and colleague, Graham Copeland, co-founder of C2AI. We both met working in the Department of Health when he was the National Director for Clinical Audit. And I think we shared frustrations that there was an obsession with statistical death rates as pretty much the exclusive metric of quality in healthcare. And we both believe there's more to life than death. We also believe that there's another way of looking at hospital performance, in that there was a preoccupation at the time with management KPIs, efficiencies, throughput, which is all very important. But if you lose sight of quality, then there's a problem in what is essentially a service for patients. So we believe really the ultimate measure of a hospital's productivity is, are they saving lives and making people better? And pragmatically speaking, you have to be able to do that as cost effectively as possible. And if every patient were the same that came through your doors, and every hospital had the same suite of services, it'd be quite easy to compare outcomes, but that's not the case. Effectively, what we've done is develop a system that operates slightly more scientifically. Rather than looking at a catchment population statistically, we take clinical measures about every patient that comes through the doors to understand their presenting risk, and then take a series of, think of us like an MRI scanner, a series of scientific slices of the organization to identify, with relation to the patients actually being treated, are the outcomes appropriate? What's going well? Specifically, we want to look at good practice as much as anything else. This isn't a policing system, so that we can replicate that. What's not going so well? And critically, if we identify problems, what's the root cause, the reason for it happening, and what's the remedial action plan? What can we do about it? So that we're on a route to improvement rather than just pointing fingers. And I think we've got very similar figures to what Andrew was picking up, that there's an awful lot of waste in the system from our perspective as well, in terms of avoidable harm and variation, largely because it isn't being measured at all. We've got a small cherry-picked set of KPIs around things like falls and pressure ulcers, but the vast majority of harms are often from omission to treat rather than active error. It's nobody's fault, it's systemic. But in the US, for example, the published figure is $750 billion of waste every year. And if we look at the kind of liabilities that NHS resolution is facing, it doesn't seem like the UK is faring much better. Now, we're taking scientific slices of the organisation and we're picking up effectively 10 times more than standard hospital systems are able to do. We've been working with quite a lot of high reliability organisations in the States, and even they were finding they could only get visibility on 1 in 7 of the issues that we could highlight for them. And it's based, we could do this because it's based on a lot of research. 30 years of Graham and his team's work. We've now got the world's largest referential data set of over 150 million records. And we're tracking pretty much everything that goes on within the hospital walls around surgical complications, medical and nursing indicators of avoidable harm, what we call triggers, drawn from the global trigger tool. And we're covering, with an automated system, every patient that comes through the doors and all of their diagnostic profiling, rather than just picking out the principal diagnosis. And from that, as you can see, we can deliver some fairly robust improvements that also deliver robust savings that are in-year OPEX reductions, because dealing with complications and problems is expensive. So, quite important context, even though I want to focus for the rest of this presentation largely on the left-hand side of this slide. The key thing is that we have a product range in 2 halves. On the right-hand side, we have a system called CRAB, which is the retrospective audit of the organization. So we're trying to get a real baseline view of what's going on within the hospital, what's going well, what's not going so well. And including within that now is the ability to produce risk-adjusted outcome analysis of COVID patients, the treatment of COVID patients. But the ability then to find out where are the hotspots and what can we improve. At that point, we can deploy what is on the left-hand side of this slide, which is Compass, which is a suite of tools to put in the hands of doctors and nurses at point of care, typically at point of admission, to triage patients. Initially, this was about individual patients, and that's one of the key things Sanjay is going to talk about, is how do we preoperatively risk assess the patient in terms of their own physiology and the nature of the operation that's now being proposed. understand whether or not they ought to be optimized, and modify their post-operative treatment pathway for best results. Now, associated with that is at the bottom, a suite of prevention and assessment tools. There's an awful lot of AI that's focused on increased see and treat. And what we're trying to do is prevent stuff happening in the first place, particularly some of the high volume, high harm, high cost issues like AKI, hospital-acquired pneumonia. How do we identify the patients most at risk of developing those conditions and prevent it from happening in the first place, with some fairly simple smartphone-based tools that doctors and nurses can download to their personal devices. And then you can actually, we've now modeled it and we're talking to Northwest Coast about it, we can automate some of that to create effectively an automated surgical list triage system that would help cut through a lot of the assessment of patients for the working on the elective restart. So how do we identify who's at greatest priority in terms of who should be operated on, who actually may be higher risk but would benefit from being optimized before we operate. And at the bottom, the good thing about this for us is that for the FDs and CFOs in the room, we can demonstrate that actually it is true, the path to lowest cost is the same as the path to best quality. So we have an economic analysis that demonstrates as you improve quality, you release a huge amount of capacity and in-year OPEX savings. And if we extrapolated what we do currently with 14 trusts in the US, in the UK, around the world, Healthcare UK independently have suggested that we'd be able to be saving 75,000 lives a year and deliver about £1 billion of savings. So that's not our figures. Shifting on to the app, which is the key focus of today and Sanjay's talk. It's a smartphone-based app. It's a simple download from the App Store on a one-click that we email to people. It's got a 2-minute training video and it can be deployed immediately afterwards. There's no PID involved, so there's no IG or a GDPR clearance to be had, and you can apply it immediately with a simple series of digital checklists, which produce a predicted risk, in this case of AKI and HAP in particular circumstances in the hospital, and some advice on how you then treat the patients at greatest risk, with the result that in practice, we've actually delivered quite a degree of released capacity, because an AKI patient, once they've developed it, will stay on average an extra 6 to 8 days in hospital, and a proportion of those will take up ICU beds. We can release an awful lot of that capacity, which helps to, again, increase the ability to deal with some of the elective backlog. And again, some practical results from around the world. We've been able to deliver at least a halving of these conditions, sometimes within weeks. Moving on to the preoperative side of things, this is the web-based version of the tool, but it exists also on a smartphone. It's a simple set of drop-down menus. You adjust what's abnormal, and what you get for each individual patient is a personalized risk of death and complications, but more importantly, a schedule of which complications are most likely for this specific patient. And that gives far more informed consent, but also far more decision-making support for the clinical team about what the post-operative pathway should look like to minimize those risks. And as I mentioned earlier on, if we take that into an automated scenario, we can be taking some coded information about the patients and apply it to them in large groups to understand who are the ones to prioritize with the most urgency, not just looking at the basic scoring of the urgency of the procedure, but the urgency for that patient as an individual, and who could be optimized first, so that we can, forgive the pun, flatten the curve on the bulk of elective procedures. We've also won a bunch of awards for what we've been doing recently. Very proud of what the team's achieved. I'm just basking in reflected glory, really. And actually more important for me is the fact that we carry with us, like SERENUS.AI, a huge amount of clinical engagement. So we're really proud to have the kind of testimonials that we get from the clinicians that we work with. And that's really important, that this isn't just another IT tool that's put upon them. It's something that they deem to be useful and usable. And that's my neat segue to Sanjay, who I hope will back me up on that claim. And very, very proud to have Sanjay as one of our champions.
Cheers, Steve. I'll just start to share my screen. Okay, so just to put things in context, so I'm a consultant general upper GI surgeon based at Western Hospital, St Helens and Knowsley Trust, which is in Merseyside. Graham, who's here with me, I've known Graham since I was a medical student, actually. So we both have a healthy paranoia of surgeons when we operate on patients. If they have complications, was it us? And if it wasn't us, what can we do to try and improve the situation for them? Surgery is actually very, very easy. What is difficult is the decision process of making the right decision for that patient. And as time has gone by, it's got to be a shared decision process. A lot of the strategies that we use have been kind of put upon us quite rightly, for example, by the General Medical Council with regards to informed consent. The unfortunate episode, and most of you have probably heard about Montgomery and what's happened to Nadine Montgomery, that's actually quite telling as to how we should actually be looking at patients and actually individualizing the risks and the complications for them. As I've already highlighted, NHS resolution litigation, the costs are exponentially rising. And so from our point of view, having an accurate assessment of somebody's risk is actually really quite important. So we can therefore target the resource in the sense that if you have a high-risk patient, you know that they may well require level 2 or level 3 care, and therefore designate those lower-risk patients to a more appropriate facility. I put in here also zero harm and our potential ambitions. And I know that Steve and Graham have done a lot of work with some of the North American hospitals. And there is a group of hospitals called Essential Hospitals, which are a group of 80 Catholic hospitals, which are roughly 50% size of the NHS. And their strapline was zero harm, which I must say is actually commendable and something that we should be aiming for. These are some of the kind of risk prediction scoring systems that we've been using over the past 40 to 50 years. And most of you have probably heard about ASA grading, perhaps Apache 2 scoring as well. Graham developed POSSUM scoring, which is what the CRAB system and also the COMPASS systems are based upon back in 1991. And I was obviously a lowly surgical SHO at that time. And through the 90s and 2000s, I've actually grown up in this country using POSSUM on a regular basis. And most surgeons in this country will know of POSSUM. There have been various iterations of that. I won't describe any of them. But as Steve has already said, is that the database that they use is well over 140 million patients and 55 million surgical patients. And this is where the systems that they use actually interrogate the hospital system, i.e. the outcome data, the HES data that is returned. So we know how accurate it is, and they are therefore have tweaked their algorithms to actually try and improve the risk prediction for these patients. So we're going to briefly talk about COMPASS. For a surgeon, this is probably the most uncomfortable and difficult conversation that you will have with a patient or their relatives, is when things do not go to plan. Having a system that is able to accurately reflect what the likelihood is makes it a little bit easier. This is a screen grab from one of our documents that we currently use at Whiston, which is the acute assessment performer. Our former medical director, Kevin Hardy, sat on the Royal College of Physicians working party looking at documentation. And in true surgical style, I plagiarized this and basically changed it so it actually highlights the kind of issues that we want to look at as surgeons and also as physicians regarding to patients' news score, but also assessing their AKI risk and their hospital-acquired pneumonia risk, which are significant problems for all hospitals. This is a screen grab from my phone, and I actually use this on a daily basis. So As Steve says, it opens up fairly rapidly. Within seconds, you can actually input the data as to whether you're looking at somebody's AKI risk, their hospital-acquired pneumonia risk, whether they are medical patients looking at different trigger scores, or actually as a preoperative assessment. This was a patient I admitted 2 days ago who came in at the age of 68 with small bowel obstruction. Patient was a diabetic, he's got ischemic heart disease, also had diverticular disease, and within seconds we're able to look at what their risk of developing acute kidney injury would be and put advice for nursing staff and medical staff as to how to try and assess and therefore treat this patient. This is the Compass tool. Again, it takes you 30 to 60 seconds to actually use it either on your phone or as the desktop variant. Again, this unfortunate patient is coming into hospital with fecal peritonitis. He's going to end up having a laparotomy under my care. The beauty of this system is that obviously if you do not have those results available, it will default to the normal variant. So when we go through, we can see that this patient's risk of a complication is almost 60% and their risk of death is actually 42%. Now, obviously all emergency hospitals are actually enrolled into the NELA pathways. Hopefully that will activate that this patient should be admitted to a level 2 or level 3 facility then. This is a breakdown of those complications, and in that it highlights that this patient's got a 1 in 5 risk of having a chest infection. Hopefully that should alert the medics and the nurses that this patient needs chest physio, should go to perhaps level 2 ward. But also what we would like to see is that we actually give this information to the patient. And if you're a lawyer or if you're a very savvy patient, you should turn around and ask your physician or your surgeon, well, if I've got a 1 in 5 risk of developing chest infection, what are you going to do to prevent me from that happening? So at St Helens and Knowsley, we use the CRAB systems, we use Compass, we use AKL toolkits as well. We are currently using paper-based versions. We are trying to go digital, and we're trying to actually get these systems integrated into all of the hospital IT systems as well. What Compass is able to do for us, because we have a standalone day case unit that's 4 miles away from our acute site, it will be able to trawl through the and triage our waiting list and tell us which patients would be suitable as day case and which patients would actually probably require a level 2 or level 3 facility. The AKI risk is something that's been highlighted by our CRAB system, is that we do have a high risk of AKI with medical patients and surgical patients. And if we put these measures in place, we could potentially reduce our cost by about £1.3 million. Because of that, we now have a variety of groups, which we call the hydration group, that have brought forward the nutrition teams, the IV hydration groups, IT, to try and look at how we can try and integrate these systems to try and actually hopefully improve these outcomes for these patients. We know that hydration is actually deeply involved with actually the hospital-acquired pneumonia risk for our patients. And we've done a retrospective analysis of surgical deaths over the past 2 years. And in amongst those deaths, that we have put hospital-acquired pneumonia down on the death certificate for 45% of these patients. That's of some concern because those are potentially reversible. And the argument would be that if you did not give these patients post-op physio or reduce that risk, then you are potentially culpable for that death. Our new medical director, Rowan Pritchard-Jones, is a bit of a computer whiz kid, and he's quite intrigued of using these systems and developing what he describes as a data lake, where we can hopefully electronically pull all this information of blood results, the patient's observation scores, and their AKI risk, and perhaps their Compass risk as well. Looking forward, the technology is currently available for us to actually real-time track this today. What I would like to see is that when I do my ward rounds, is that there is perhaps an iPad or whatever device you may wish to use at the end of the patient's bed that will track their news score, their AKI risk at the time of admission, and their Compass score. And if you do it as a dashboard, one would like to think that you will improve this rather than making it worse. The aspect of monitoring is that obviously clearly we need to be able to track as to what we are doing and see what our outcomes are like before we can feed back to see whether we need to tweak that any further. For those of you who perhaps like driver diagrams, this is a bit of a tall ambition for us. It's something we need to try and achieve, and our focus on the primary drivers is that we need to be able to find accurate tools that are, as we described earlier, easy to use for the nurses and the doctors, so we can actually assess these patients, communicate that not just to patients but also to colleagues, but actually also continue with the education and repeating that, because as Hemant mentioned earlier, is that the junior doctors are constantly changing. They may not be aware of these systems, and we need to try and repeat that on a regular basis. Thank you.
Thank you very much indeed, Steve and Sanjay. Thank you very much indeed. What a fascinating, again, presentation from you both about you know, clinical prioritisation, triage, the potential to do elective triage at scale to make informed decisions with the patient about the best treatment option for them, to inform the clinical staff of the specific needs of that patient, post-procedure, pre-procedure, and you know, obviously evidence from the deployment in St Helens and Knowsley just about the impact that's having on patients, on the reduction in harm, and also the reduction in cost. So it's been, you know, fascinating for me. I've learned a lot today. I think it's coming at a good time, this discussion and this big innovation conversation. Obviously, we know that trusts have got to maintain their elective capacity and capability whilst managing COVID and the imminent, if not already here, second wave. And I think what we've hopefully done today is we've been able to describe, you know, just how you might do that, but not just from a art of the possible perspective, from a, you know, from the perspective of places where it's already being done. So really good and insightful discussions today. So I'm just keeping my eye on the chat and on the time. I think we've got time for maybe one question, maybe two questions. So I think this is an implementation question, I think, for Steve and Sanjay, and it's about, you know, when you've got the you know, something like this platform, so Compass, what support do the wards and the theatres and the clinics need to be able to implement and engage with this tool and get the best out of it?
Very good point. Obviously, we've got certain individuals who've embraced this, and, you know, Graham and I have been pushing for the past 3 years trying to actually get this on board, and we've been working very closely with C2AI trying to do that. The difficulty we have is that in the hospital, we have different hospital systems, for example, Medway, System C, and what we're trying to do is actually integrate, you know, the C2AI systems into those other hospital systems. And that has been really quite difficult in trying to push that, really. Yes, it's great having it on my iPhone. I can actually do that when I wander around, but it's just trying to access that to make sure that it's, you know, readily available for the nurses and the medics on the ward.
Yeah, if I can add to that,
yeah.
I think it picks up on a question from Andy Cairns as well, about there being a paper-based version. I think what we've tried to do is make this available as widely as possible in as many formats as possible. So there is a paper version available. The ideal is that this is integrated with EMRs, and therefore it's readily available in whatever fraction system is deployed in any given hospital, so that nurses and doctors can see the results immediately in the EMR. But our point of departure is actually all our systems begin with zero integration, because that is the biggest stumbling block. It's not a stumbling block with the doctors and nurses embracing the kind of thing that improves outcomes. It's just the integration with big vendors like Cerner or Epic, finding the time to bother themselves with these sorts of things. So that's why, as a starting point, the app is an instant download with no PID involved, and can be used as soon as you've got it. The ideal is that then the results can be fed through into an EMR. Same with CRAB, that we take a simple Excel file data feed from the hospital, and we can run everything external to hospital IT systems in the first instance. But we would equally, like Sanjay, love to get to the point where we can switch on an API with Epic or Cerner or System C and feed that data straight through again.
Yeah. Well, let's hope you don't have to wait too long for that. I suspect you might, though.
It's very straightforward on our part.
Yeah, well, I was going to say you're very willing. It's them, isn't it? So, yeah, again, you know, asked and answered. Great answer to that question, and some great context setting as well. And thank you both. So I'm conscious of time, so I think I'm going to wrap up. There are no more questions in the questions and answer box. So I think I'm just going to wrap things up today by saying to our delegates, thank you very much for being part of this big innovation conversation today. We really appreciated having you along, and I hope it's been interesting for you. But also thanks to all of our speakers, to Steve, to Andrew, to Sanjay, and to Hemant as well today. They're giving up their time to do this. You've already heard about our clinicians being literally in the middle of clinics and things to be here today. So we really appreciate that. Thank you all, and perhaps we'll see you at the next big innovation conversation in a month's time. Thank you very much. Bye-bye.